Hi everyone, and welcome to the fourth of our Nuclear Masterclass webinars. I'm Professor Helen Boston from the University of Liverpool. My background is nuclear physics and medical physics instrumentation. So, without much ado, I'd like to introduce our speaker for tonight, Valery Radchenko. He's based at Triumph, which is Triumph University's Meeson facility out in Vancouver, and he has an adjunct professorship with University of British Columbia, and I believe you're also on secondment at the moment with IEA. So, leave it to you.
Thank you so much, Helen, for the nice, kind introduction, and thanks everybody for joining. And I also would like to thank Christian and Katrin for inviting me and organizing this webinar. And I will talk today some about the nuclear medicine and how you can use the radionuclides in the radiopharmaceuticals, and you can use them for imaging, and you can use them for therapy. And I have a title of my talk using the modern alchemy, which is now called radiochemistry, and how you can use them in nuclear medicine. Okay, let me move to the next slide. First, let me introduce a little bit of place that I'm working on. It's Triumph. Triumph is a Canada Particle Accelerator Center based in Vancouver, Canada. And this place was founded in 1968. And a couple of years, 2 years back, marks 55th anniversary of Triumph. And what is really unique about the facility, the Triumph facility, is that this is the national lab. But in contrast with the many other facilities or national labs around the world, it's actually not run by this department or a specific organization. It's run actually by universities. So there's a consortium of over 20 universities across Canada, and you can see the map of Canada. And initially it was founded by pre-university, University of British Columbia, Simon Fraser University, and University of Victoria. So that's why it's called Free University Mason Factory. So this was the initial name, but now, thanks to many other connections and experiments, we have really broad variety of different universities across the Canada, from one coast to another coast, that are members of Triumph, and actually deciding what scientific programs we have and what facility we're going to invest and build. And so there's also just today I would focus about nuclear medicine and life sciences division. So let me make the laser pointer. So, you know, I want to be transparent that Triumph is actually not only about life science and nuclear medicine. It's much more wider variety of different research that it's offered or conducting. So it starts from the, all the way from the dark matter and cosmology, going down the scale to the nuclear astrophysics, electronics, radiation testing in the space, then nuclear medicine that I'm going to highlight today, and also molecular and material science, nuclear physics, and then particle physics. So there's a really wide range of varieties of research we're conducting at Triumph. And we also have, to the students in the audience, we also have very active student programs, so core programs and grad and undergrad programs. So, if you're interested for some study in the future, this can be maybe opportunity at Triumph as well. Okay, so now I would like to move to my content of my lecture for today. And this is kind of content that I will try to cover over today's lecture. So I will start with short introduction, some motivation for myself, why I'm working on this area, then some basics of the radiopharmaceuticals, and then I will move into the two big aspects of radiopharmaceuticals. It's using the radiopharmaceuticals for imaging, so single photon emission tomography and positron emission tomography, so diagnostic using the radionuclides, and then also targeted radionuclide therapy with using the different particles. And I will just explain what's the difference and when which particles is used for which approach for the therapy. First, I would like to start with some, as a chemist, I would like to start with the periodic table of elements. And just when I talk about my motivation, why I'm working in this area and why I'm doing research in this area in nuclear medicine and radiochemistry, is that as a chemist, you have all these tools available to you to do your any projects in chemistry. So you have 118 elements so far known in periodic table, and this is all your tools that you can use. But for radiochemistry, what really excites me, I'm sure many of you are familiar with this as well. So this is the previously it was periodic table of elements, but this is chart of radionuclides. And this chart of radionuclides highlight not only elements, but also isotopes of elements. And you can see, there's line instability in the middle, and there's a proton-rich radionuclide. So number of protons on this scale and number of neutrons on this scale. And then this practically, there's over 4,000 of different radionuclides known so far, and there's more to come. But what really excites me in my field in radionuclide production and radiopharmaceuticals is that, instead of only 118 tools that we can use over thousands of different tools for different approaches. And this is what really my motivation for being a researcher in radiochemistry. Let's start a little bit, go back to the history and just to see where all this started. So first idea of using radio tracer principles. So radio tracer means we label something. So practically radio label something with a radioactive radionuclide. And this come from George de Havisham. So this is the Hungarian researchers who did his research in UK. And he got a Nobel Prize in 1943. And the reason why he got a Nobel Prize is because he studied the distribution of the lead element in the plants. And he was just puzzling how he can do it without possibility to measure the lead. And then he came with a concept that, what he can do, he can actually spike the element of lead with a radioactive lead to 12 with a 10-hour half-life. And this is radioactive tracer that he can actually detect with the by its emission with a detector. So he practically add the lead with a spiked lead to 12 isotope into the water of the plants, and then these plants would suck the water, and lead would distribute it to different parts of the plants, and then he can cut the different parts of the plants and measure radioactivity in these plants, and it's the way he can find the concentration of stable lead in the different parts of plants using the radioactive tracer. There was another story as well that also explained this principle, but in more kind of, convenient way. So he actually was living in the house or renting the place in the UK, and he also got the option that he can get breakfast included. And then he starts to suspect that his landlord actually using the same ingredients for his new breakfast from the ingredients from the previous breakfast from the previous date he didn't finish. And he cannot just claim this because he didn't see this, but what he did actually, he brought some radio tracers, so some radioactive isotopes one day, and he spiked his meal with a radioactive isotope, and then come next day with a Geiger counter, and then just detect and see if there was radioactivity. And in fact, it was some radioactivity in his meal. So this way, he was really indicating that his landlord was using the practically the leftover meals from the previous day for cook his new meal, which was not the part of the deal. So, but idea is the same concept that I highlighted before with the lead radio tracer using the lead distribution. And what is even more excited that now there is no really difference in the concept we're using in nuclear medicine. Exactly the same principles that we are now using in nuclear medicine. So same idea, but in this case we have a specific target, which usually can be cancer, can be neurodegenerative disease, can be heart or a blood system, that some defects we want to detect. But most commonly, of course, we use this tracer principle in nuclear medicine for the cancer detection and therapy. And then we have a tracer, which is can be a common tracer. For example, for cancer, it's a commonly used as sugar molecule, because cancer cell is the cell which dividing kind of more rapidly and more faster. So therefore, they need more food compared to the healthy cells. And for that, they just would consume more sugar compared to the more food practically compared to other cells, the healthy cells. Now, question how we would detect the sugar molecule, same problems that George de Havilshire had before, and same answer. We can just spike it with a radioactive isotope. In this case, it would be fluorine-18, radionuclide is commonly used for positron emission tomography, which I will talk in the next couple of slides. And then we will see now the behavior of this molecule with the practically tomograph or the detectors surrounded this tumor site, that we can see the image and practically distribution of sugar molecule labeled with F18 in the patient. And as you can see on this image, this black spots across the patient body are indicating that there is some increased consumption of the sugar, which means potentially some lesions and some metastatic cancers. Of course, there are some organs, for example, brain, which naturally take uptake of the sugar. It's much more higher. So in this case, we cannot really detect if there's anything going on in the brain, but you can see through the body, there's definitely some lesions that need some attention from the doctor. Over time, of course, we also start being more selective. So in this case, we talked before about using the sugar molecule, but sugar molecule, it's not really specific to the cancer cell. There's no really receptor on the cancer cell which would be selectively uptake the molecule of the sugar. In this case, we come up with new molecules which can be peptides or antibodies, which much more selective to the cancer cell. So they would have receptors on the surface which would be very specific to the receptor on the cancer cell, and then it would be selectively taken only by cancer cell and would not do anything with the healthy cells. And in terms of radionuclides, we also get some evolution in terms of because with the organic molecules, we only can replace element of oxygen, nitrogen, carbon, or for example, fluorine, but we cannot use the radiometals anymore. So in this case, we introduce this concept of the chelator. So chelator, it's in the way some organic molecules which would strongly bind the metal, but then at the same time would have some linker that can be attached to the peptide or antibody of this biomolecule to hold it strongly together and deliver it through this peptide or antibody to the targeting site, which again, we're still battling the cancer, and there's still a lot of more and more cases, number of cases increase in many types of cancer. So practically, this concept is mainly used for diagnostic and treatment of the cancer. And I will mention this later, but practically the difference is that how we can use it for diagnostic and for therapy, we're just using the different radionuclides. So we use the radionuclides which emit positrons or photons for the diagnostic, and then we use the radionuclides which emit beta minus particles or alpha particles or Auger electrons for the therapy. We're practically just replacing same construct with the different radionuclides. And then let's now move to the diagnostic part and talk a little bit about which radionuclides we can use for diagnostic. So as I mentioned, we go back to this chart of radionuclides, and we can see that for single photon emission tomography, we practically only need the single photon, so the gamma quant emitted by the radionuclide. And as you know, probably many radionuclides emit the photons, so we don't really need very specific radionuclides. But what we really need to pay attention is the energy, and I will show you on the next slide why this is important. But practically, this is the couple of examples of radionuclides that are emitting photons and conveniently use for the SPECT imaging. And technetium-99m, this 6-hour half-life, this is the main practically candidate for main radionuclide used in SPECT imaging nowadays. And for other option, it's a positron emission tomography. So we use a positron, which is antiparticles from electron. And then we will need practically isotopes with neutron diffusion on this side of chart of radionuclides that are commonly decay, emitting positrons. And this is a couple of candidates. So F18, as I mentioned, 2-hour half-life, very common radionuclide that used in the imaging. There's also some couple of radiometals I mentioned, which can be used using the structure outlined here on the previous slide. So gallium-68 is about an hour half-life, and then zirconium-89 is for some longer circulation process with over 3 days half-lives. Okay, so let's now move to the SPECT and just kind of talk a little bit more about some details of the technique. So as I mentioned, we only need the radionuclide that emitting photons. So in this case, there's many radionuclides that are suitable, but one limitation that we need to pay attention to is the range of the energy. So practically how deep can this photon penetrate into the through the tissue and into the detector. So from one side, if the energy is too low, so practically, if we have some range below 100 keV and lower, problem can be that this photon just simply cannot penetrate through the patient and reach the detector. So this is the problem from one side, that we cannot detect it even if we have labeled the compound with this radionuclide. And then from other side, if the energy is too high, it simply just go through the detector and would not leave any signal in the detector. So, this is something that we really need to pay attention when we choose the radionuclides, is the energy range of the photon should be somewhere ideally between 1 and 200 kilo electron volt. But with a new technology, with the different collimators, now this can be changed, and there's much more broader variety of different radionuclides that can be used for SPECT imaging. But principle, it's very simple. So there's a detector which would detect the photons, and it's just going back and forth. So the patient would lie on the bed, and before the patient would come to the spectrometer or the detector, the radiopharmaceuticals based, as I showed you before, on peptides or antibodies labeled with a SPECT isotope would be prepared, injected to the patient, circulate for some time before they reach the optimal ratio between the healthy and potentially tumor tissue. And then the patient would be invited to lie on the detector, and then the scan would be taken. Approximately take sometimes below an hour for taking this image. And then it would be analyzed, so you can see this. There's some example of the images of the SPECT. So another technique, which it's more precise and more kind of provide you more high resolution compared to the SPECT, it's PET. And the reason for that, because the positron emission tomography based on decay of, annihilation of positron. So practically, positron is a particle which is antiparticle from this electron, and there's a lot of electrons in our environment. So practically, what's happening when radionuclide emit positron, it would fly sort of distance before it would find electron, and then they would annihilate. So it practically would disappear, but they cannot just disappear without creating something. So they create the energy, and this is energy created in the form of the 2 photons with energy of 511 kiloelectron volt. And what's unique, these 2 photons would fly in 180-degree angle. So instead of just making one line with decay of photon, you would make practically 2 lines from one detector to another detector with decay of the positron. And that's what really make this much more precise, because instead of just having many single lines to one detector, you would have array of the detectors around it, so tomograph around the patient, and then you would see a different distribution range. So for example, in this case, you see this patient have some lesions in the area, abdominal area, and there's a different probability. So you see the red and the green and yellow colors indicating practically the probability of location of this radiopharmaceutical specific to the disease that it's detecting. One more important point is that, as you can see as you see from the previous slide, you just see practically a shiny dot in the patient, but for doctor to identify which organ is affected and where is located, anatomic structure of the patient is also very important. So therefore, there's also often the combination of PET and SPECT tomographs with the computed tomography. So there's another practically X-ray or CT image of the patient, which practically showing the anatomy of the patient, and then combined with, for example, in this case, it's PET CT, clearly show the organs which is affected. And then for doctors, it's much more easy to identify which organ and what therapy options to prescribe. Now let's move to the targeted radionuclide therapy. So now we talk about how we can diagnose and detect the disease. And now, since we know there is a need for treatment, we can also use not only surgery or chemotherapy, but we also can use radionuclide therapy. So we also call it targeted radionuclide therapy. And for that, we can use a different emission or different radionuclides emitting different particles for the therapy. So practically, we destroy now the cell that we target. And there's a different emissions that can be used. So there's beta-minus emitter. So there's beta-minus particles can be used. And they usually located in this neutron-rich part of the chart of radionuclides. We can also use alpha particles. So this is double chart helium nucleus that we can also use for the therapy. And this is usually located in this high Z area. So we see this yellow color across the chart of radionuclides, which indicate alpha decay of radionuclide. And then something that is now just an experimental stage, but also present high potential for the therapy, it's also Auger electrons. And so Auger electrons, it's usually presented by electron capture, and they usually can be many radionuclides actually emit Auger and conversion electrons. So they can be located from both sides of the line of stability. And now let's talk a little bit how we choose the different emissions and which situation for the therapy. So it's usually come to the combination of the energy, so practically how much power this particle is carrying, but also at the same time is what is the distribution of this energy, so which called linear energy transfer. So that means how far this particle can penetrate through the tissue before it would release all its energy. And as example, for beta emitters, for beta-minus emitters, this linear energy transfer is slow. So what it practically means that the beta particles would fly relatively long distance. So we're talking millimeters in the tissue before it's released all its energy. So it means that it doesn't really like to give the energy away. So it would just go relatively long distance before it would stop. And in this case, we probably would use the beta particles therapy for some tumors, which is relatively large. So we don't want to use it for single cells or small tumor clusters. On the contrast, for other particles, for example, for alpha, there is also high energy, even higher than the beta. So they really carry a lot of power with them. But at the same time, they also have a high linear energy transfer. So that means they really like to give the energy away on the decay path. So they would only go micrometer distance, which is comparable actually to the several cell diameters before they would release this giant amount of energy. In this case, it's really much more potent for this targeted therapy because we now talk about, really we deliver the radionuclides with very selective molecule. And at the same time, if it just not specific to the cell that we're targeting, it's not really targeted therapy anymore. Of course, it's targeted, but to the certain area. But with alpha particles, we really can now talk about targeted therapy because it's only affect several cells that it's delivered to. And at the same time, that's why this therapy with Auger electrons seems to be theoretically even more potent because they have low energy compared to beta particles and alpha particles, but at the same time, they have high linear transfer. So they would release this energy just within individual cell, which is potentially make it most targeted option for the therapy. And as you can see, this is just an animation from the paper talking about different range. So we see, for the beta particles, it's go thousands or millions of cells before it would release and stop in the tissues. With the alpha particles, we can really count. There's only dozens of cells. But then for Auger electrons, it's only practically one cell that we can affect by the decay of this radionuclide. And just briefly now, I want to go through the all these options and kind of where we stand with the different options with the therapy, with the different particles. So for targeted beta therapy, there's already commonly used in the clinic. So, there's a published work by several groups that routinely use radionuclides like lutetium-177, yttrium-90, iodine-131 for the patient therapy. And this is the example of the patient which was diagnosed with the prostate cancer. And as you can see, there's a PET positron emission tomography scan with gallium-68. So this is the radionuclide that I mentioned, which is suitable for PET. And you can see there's many black dots. So this means indicating that there is a lot of already late stage cancer with a lot of metastatic formation. After this patient received the therapy with the same compound, so you can see this peptide called PSMA with lutetium-177. So this is the therapeutic radionuclide. And usually it's not only one dose, so there's a different cycles of that the patient receive over the time. So you can see after first cycle, it doesn't really change much, but second, third, and fourth cycle really make significant difference compared to the image in the first image on the left. So this is something that indicating the potential of the using the radionuclides for the therapy. And on the next slide, I have a short video, and I just kind of want to animate a little bit how these radiopharmaceuticals are prepared, injected, and what they're actually doing inside the patient. So, and I will just explain you through the video what is each step are doing. So let me start playing this. Okay. Just go from the laser pointer mode. Okay. Now should start playing. Okay, so you can see now on the screen there's practically just making the radiopharmaceuticals. So this is the peptide which is selective for neuroendocrine tumor, and through the chelator, through these organic compounds, we was able to add lutetium-177, which is beta minus therapeutic radionuclide, which from one side will emit beta minus particles, which would destroy cancer cells. But from the other side, it also have photons. So in this case, we can use it for the imaging as well. And then we prepare this radiopharmaceuticals injected to the bloodstream of the patient. And it will take some time to circulate in the blood system to be able to accumulate in the cancer site. So in this case, we can see there's a tumor and there's a blood vessels practically going around the tumor. which would deliver this peptide radiolabeled with lutetium. Then it would internalize inside the cell and would keep decaying. So it's not means it's just decay only when it's delivered. So it's always keep decaying, but some of the radionuclides would be delivered into the cancer cell and then would practically destroy this with a beta minus particles. So it would damage the either DNA or critical parts of the cell. And then with a SPECT camera, we practically can see after each treatment courses what is the effect. So there's still some cancer present after first injection, but then after second injection we clearly see some improvement with the patient. And this was video made by the colleagues from the COST European Association, European funding that working on some of the radiopharmaceuticals development. And so this is overall principles on example of beta minus particles, but let's now talk a little bit about some therapy using the alpha particles. So as I mentioned, the alpha particles have high energy, short penetration path, so they really would be much more suitable compared to the beta particles. So what's the problem? Why we don't use them? So the main problem actually is the availability of these radionuclides, because as I show you on the first slide, so practically you would need high Z elements to which decaying by alpha. So you would need really some facility like reactor or high energy cyclotrons to produce these radionuclides. And there's a couple of candidates that are summarized in this table that would be suitable radionuclides for the targeted alpha therapy, which of course one important parameter would be the half-life. So you can see some of them only have a minus half-life, so we really need to be very quick to deliver them. Some of them really have a day's half-life. So for example, actinium-225 is one of the headliners right now for the targeted alpha therapy, and we can see that another important parameter other than the half-life, it's also a number of alpha decays. So because if we're talking about beta minus emitter, they usually decay only once to the stable element, but for alpha emitters, because there's no really stable line of stability, it's there's not really stable targets after bismuth, so we really or stable elements after bismuth. So in this case, we really go through the chain of the decay before we end up to the stable letter bismuth. In this case, a number of alpha decay are also playing a role, because it's practically how many decays happening at the tumor site, and this is also potentially can bring some additional therapeutic potential. And another parameter or another criteria which is very important is production method. And this is why, as I mentioned before, for the alpha emitters, it's really now are very difficult to produce them, because there is no really stable targets or stable materials that we can use as a starting point, as well as we need apply relatively high energy protons, or for example neutrons, to produce them. So you can see there's different sources that are resulting in this production of alpha emitters. But at the same time, in the clinical setting, we really see a lot of potential. That's why there's a lot of study on the new methods. So you can see there's many of these radionuclides. For example, astatine, there's another promising radionuclides, are currently in the clinical trials. Same goes for bismuth and actinium. And there is a lot of effort, also including nationally, internationally, from, for example, International Atomic Agency, that we are working towards increasing the access to these radionuclides. And that's the reason why, because as you can see from this slide, there's there's two publications which all showing the potential of alpha emitters. So one is the patient which really have a lot of metastatic cancers when he was diagnosed. But then after 3 courses of treatment with actinium-225, again labeled with this PSMA, so this is peptide molecule that are selective for the prostate cancer. And you can see that there's significant improvement in the patient. And I should also note that this effect was not, so this patient was actually treated before with lutetium-177, and he already developed the resistance. So practically this metastatic cancer continued to develop even after treatment with lutetium. And there's another example of the patient. Again, there's two different cases, but both of these publications are very remarkable. That there's a patient which, again, you can see, sorry, maybe I just make the laser pointer. So you can see that also have a metastatic cancer, and then lutetium treatment didn't help anymore, but then this patient went through the treatment with bismuth-213, and you can see significant improvement in this case. So there's really a lot of potential in the targeted alpha therapy, and community now strongly working together to develop alternative production routes for alpha emitters such as actinium-225 and others. So you can see, for example, as I mentioned, actinium-225 is one of the headliners for the therapy, and it has a 10 days half-life, so it can be used as the radionuclide for radiopharmaceuticals by itself, or also can be used as a generator, so actinium decaying through the couple of decay chain, as I mentioned to you before, that alpha emitters not only decay directly to stable lead and bismuth, but they're going through the multiple decay chains. And you see there's a number of alpha particles which is emitting through the decay, and one of the daughter radionuclides, we call them, for bismuth-213, also can be used by itself as radiopharmaceuticals. But unfortunately, right now, there is no really any radiopharmaceuticals available on the clinic, because all the clinical phase is mainly limited by availability of actinium. And I want to say that at Triumph, we actively actually working on developing production of actinium-225. There's several routes that we're employing, and we're using our accelerators to develop the routine production of actinium-225, and actually will succeed, because we now routinely deliver actinium-225 to support our colleagues through Canada on their preclinical evaluation, and hopefully soon in the clinical trials. And I just also briefly want to mention about another option for the therapy, for the targeted therapy. It's using the Auger electrons. So this is, as I mentioned, low energy electrons, and we usually call them Auger electrons, but there is also conversion electrons, there's a Coster-Kronig electron. So there's a number of different low energy electrons particles that can be applied for the cancer therapy. But at this point, this is only experimental, so there's no even clinical trials at the moment, but many preclinical studies and communities are really excited about potential of using this Auger emitters for the therapy. And in fact, for my research program, I'm actually using this mercury-197, antimony-119, and palladium-103 for the therapy. So something that hopefully coming soon, and will be the next generation of radiopharmaceuticals for therapy. And before I finish, I just want to outline some interesting concepts that currently are now state of the art, because I mentioned that we can use, for example, F18 or gallium-68 radionuclides for the imaging, and then we can use lutetium or actinium or others for the therapy. But there is a small difference because gallium-68 is a different element, so it's actually, gallium belongs to a different group compared to lutetium. Lutetium is a lanthanide, and gallium it's a totally different element. So how this nature of the elements can change the information that you can get from the image to apply it for therapy. So ideal situation, if you have same element, so for example, you have scandium as element, but one isotope which can be used for imaging, and then another isotope which can be used for therapy. So in this case, scandium-44 with 4-hour half-life can be suitable radionuclide for the PET imaging, and then scandium-47 can be used for beta-minus therapy. Same applies, for example, for terbium isotopes. There's even 4 different isotopes of terbium element which can be used. So 155 can be used for SPECT imaging, also emits some Auger electrons. Terbium-161 now really picking up as the alternative for lutetium-177, really good radionuclide for the beta-minus therapy. And 152 can be used for PET imaging, and 149 actually can be used also for alpha therapy. So there is practically 4 isotopes of the same element that can be used for imaging and therapy, which called theranostics. So you use the imaging radionuclides to get image, and then plan accordingly the therapy with a therapeutic analog of this counterpart of this element. And final slide that I have is that, I talk theory, how you choose the radionuclides, how we can use them for imaging and therapy. But I just want to present you with what we call Triumph Hot Kitchen. So this is a slide that I compiled together, practically outlining the different radionuclides for the imaging and therapy we are producing at Triumph and using at Triumph. So something that, I'm not only talking from theory perspective, but also from practical aspects that we are working day to day at Triumph. I also want to highlight that there is also, the radionuclides that we're producing pretty much representing every group of periodic tables. Very impressive. And, and you can see from color code that, some of them are used for already available, some of them are planning to be produced or can be commercially available, and there's many more different radionuclides that we are planning to produce as well. So with this, I'm thank you for your attention. And I'm really, again, it was a great pleasure for being at this lecture, and I'm really happy to answer any questions that you may have. So thank you.
Hey, thank you very much, Val. That was a really interesting talk, so I'll give you a clap there. I've learnt a lot through that. Very, very interesting. I was equally horrified and impressed by using a radio tracer to check that your oatmeal isn't from the day before. So that was good. So we've got a couple of questions in the chat, so I'll read through the ones that we've got. If there's any questions that remain unanswered, then those that are participating in it will post them into the online question forum. Here we go. Normally have questions of my own lined up, but I really don't have to. There's quite a lot of really good questions that have come in. So you mentioned biomolecules that carry the radionuclide to the cancer. Would you go into a bit more detail regarding the targeting biomolecules?
This is a great question. So, as this analog that I made before, that, you can use something unselective, as I mentioned, for example, sugar molecule, right? Which is not really selective to the cancer, but just would provide you the higher contrast compared to the healthy cells. So in this case, we can still talk about the diagnostic, using this for the diagnostic, but we cannot really do the therapy, right? Because we will damage a lot of healthy cells, because there's still some uptake in the healthy cells. So all this kind of next generation of more selective peptides and antibodies. So we're talking about, to be more specific, we talk about sometimes our immune system producing this antibodies, right? Of these large proteins that are produced by the immune system to fight the cancer cell. And these proteins, they would be only selective then to this specific cancer cell, and would not be anyhow, be taken by the any healthy cell. So in this case, we have the opportunity to do much more selective imaging and therapy. And these proteins are practically produced, by our bodies. But in the case when we use it for radio labeling for imaging and therapy, they typically produced artificially, or they extracted from the animals. But practically, idea is that the body of the animal or the human produce these different biomolecules and peptides. That practically they are small proteins. They are just chains of amino acids that are also kind of produced by different mechanism by the organism itself to be selective to the cancer cell. And practically we just extract them and use them to combine with different radionuclides for imaging and then for therapy. And in this case, we really can use them for therapy because they are very selective, much more selective than sugar, for example.
Excellent. And there was a couple of parts to this, and you've touched on some of the things, but I'll finish the rest of the question. So, are there radionuclides necessary and or the most effective payload? And could the targeting molecules carry a compound that alerts the immune system to the cancer instead?
So you're practically saying, what's the amount of these radionuclides required for the imaging and therapy? Yeah, so I think it's a very good question because, and this is where I outlined this last concept of the theranostic, is that, usually for the imaging, we need much more smaller quantities. So we talk usually in radioactivity, so in megabecquerels or millicuries or curies, and then we're talking for the imaging, we typically use between, couple of hundreds megabecquerels, or, this would be tens of millicuries to conduct the imaging. But then when we talk about the therapy, we need much more higher quantity amount of radionuclides, the therapeutic radionuclides, because we want to make sure that we are affecting the cell that we're targeting. So in this case, we usually use gigabecquerels. So this is like a thousands of megabecquerels. So the factor of 1,000 to 10,000 higher number of atoms that we need to deliver to the same targeting site to be efficient for the therapy. And in this case, it's really important to do this. As I talk about theranostic, there's still some debate how we do this, because the concentration for the therapy is much more higher compared to the diagnostic dose or diagnostic amount of radionuclide. And to your point about, it's actually, I don't know if I understand properly the question, but I think this is a very good point. Now, should we actually try to target each cancer cell, or we can just help our immune system actually to just to activate it, right? So maybe we don't really need to bring this therapeutic radionuclides to each single cancer cell, but we can just activate the immune system to start working itself to destroy the cancer cell. I think right now what we're doing in the clinic, it's really with pretty much targeting to destroy every single cancer cell. This is at least the dose the doctors are planning for the therapy, usually aim to kill each individual cancer cell. But I think now the community are kind of start thinking about if we should apply the different mechanism that we just activate the immune system instead. So maybe we don't need bring such a high doses to the patients, and just find a way that we activate the immune system. I don't know if it just, there's a lot of discussion.
Yeah, I think it's a really,
answer.
I think it's a really interesting question as well, as to like the research that we're doing now. What's going to be the emerging factors from this, and it might be that it goes in a different way, but we use the basis of what we're doing now in future in a slightly different way.
And this is what I mentioned, the point that you have a different radionuclides on top of this, right? So first of all, you need significantly different amount of radionuclides for the imaging and therapy. But secondly, you also use very different radionuclides by chemistry, right? So you may not necessarily rely on the imaging you get to exactly mimic the dose for the therapy. So there's, all these factors are really important, and still a lot of research to optimize this. And again, we're talking about decades, because of the clinical trials take years to conduct and analyze. So, but we're going there. So I think we are optimizing, and I think we're seeing better response and better kind of dosage for the patient for the therapy using the radionuclides.
And that's always a good thing if we can use lower dose. Next question is, what are the biggest challenges in designing theranostic radio pharmacy that achieve both high tumor specificity and optimal pharmacocytokinetics, particularly when you're looking at balancing the physical half-life with the biological clearance rates?
That's a fantastic question. And I think this is something that really crucial for the diagnostic. So, in simple words, the half-life of the radionuclides really need to make sense for the biological half-life of the molecules. So in simple words, if I have antibodies, so we talk about this large peptides, which is 150 kilodalton, 150 thousandths a gram per mole molecular weight, so huge molecules. And we label them with, and they usually have a circulation of days. So, the patient need to be scanned after a couple of days after the injection because they're circulating very slow. At the same time, they're very selective to the cancer site. So in this case, we really need to use the radionuclides with a proper half-life. So for example, it doesn't make sense to use F18 with 2-hour half-life or gallium-68 with 1-hour half-life because it just simply would decay. 10 half-lives, we usually don't see anything. So it would just decay in 20 hours. And after we need to do the scan, there would be no radioactivity that we can detect. So in this case, we really need to use radionuclides like zirconium-89 with 3 days half-life for the imaging. Or vice versa, right? If we have a small peptides, which only need a couple of hours to reach the optimal ratio between the tumor to non-tumor tissues. In this case, using gallium-68 would be absolutely appropriate and would be not bring any extra dose to the patient, where if you use zirconium-89 with 3 days, it just would, we get image in a couple of hours, and then the radionuclides just keep circulating and practically damaging the tissue, the healthy tissues for nothing. So I think this is the balance that's very important for imaging. But there's a little bit more kind of debates on the therapeutic side, because in principle, same principle should apply, but we still use for actinium-225 with 10 days half-life, we still use the small peptides. So in this case, for the therapy, it's not really still optimize this balance between the biological vector and the radionuclide half-life. But I think initial question was, what's the main challenges for the radiopharmaceutical production is, I think first of all, it's availability of radionuclides, which is a huge challenge, especially for some therapeutic radionuclides. Like as I mentioned, actinium-225, you can have all the money in the world, but it's simply not available. Just many people struggle to get it. And if you start research, it's okay because you can get it, or you may get it later, or maybe next year until you get a funding. That's all okay. But if you start clinical trials, you need to huge amount of this radionuclide constantly supplied to you. And this is biggest challenge for many radiopharmaceuticals right now. It's the availability of the radionuclides and kind of the scale that is reliable. It's always not there, and especially for some experimental radionuclides like targeted alpha therapy.
I think that kind of leads on to the next one a little bit anyway. One of the main challenges that are hindering the development of the targeted Auger therapy. You mentioned that they're not in clinical trials yet, so why not?
Yeah, that's I think the main reason for that is that, and this I think this is another side of the challenge on the answer on the previous question, because I think there's need to be more developments on delivery systems, right? Because as I mentioned, the availability of radionuclide, it's something obvious. We know about this and we can work on this. But then on the same time, more advanced delivery system like peptides, antibodies, which are more selective, faster, more selective to the, more universal to different types of cancer, something very important. I think in my opinion, what is really holding the progress on different Auger emitters for the targeted therapy, it's really the proper delivery system, because as I mentioned, it's so gentle. So we're really talking about the single cell. So when we deliver the radionuclide to this particular cell, it's only going to damage this particular cell. But even the concern is that maybe not enough energy to damage significantly the cell that is going to die or not function anymore. And delivery system which bring it to the crucial part of the cell, for example, DNA, that's something what we're still missing. So there's another challenge with the Auger emitters is that we have a radionuclides that emit Auger electrons, and as I mentioned, many of them, many radionuclides emits Auger electrons. There's no really, specific electron capture. There's hundreds of radionuclides, thousands of radionuclides decayed by electron capture, but just kind of combination, because now many labs are using the radionuclides that are commercially available for their studies, but they're not necessarily the best for Auger therapy. So because they have another emission, they have a longer half-life, they have some disadvantages that prevent them to be efficient for the therapy. But just simply because, again, they're commercially available, the groups who are not producing radionuclides can buy them, they're using them. And this is another kind of factor that is slowing down because the not optimal radionuclides are used for the studies. And again, as I mentioned, having the really delivery system that bring it ideally to the nucleus or close to the DNA would be the game changer. And I'm sure Auger therapy would then be the top therapy over the alpha and beta minus.
Oh, okay, great. We're coming up towards the end of the session, and I think we could talk for hours on this. But I think we'll just look in the Q&A for the last question. Sorry, my eyesight isn't as good as it once was. So are there any specific radionuclides which are, oops, just jumped. Yeah, are there any specific radioisotopes which are more promising from a production standpoint? Any ones that you're particularly interested in? And how far do you think we are from being able to mass produce some of these radionuclides for medical purposes?
I like this question. This is really along the my research line. So I think what really excites me, again back to last point about the Auger emitters. As I mentioned, for many beta minus emitters for the therapy, you need the reactors, and reactors is not something that you can find in any research center. There's maybe small research reactors are quite common, but there's some countries or there's many places and institution which doesn't have access to research reactors with a sufficient flux of neutrons that can produce clinical quantity of beta minus emitter. Same with alpha emitters, as I mentioned, because they're so far from the line of stability. Not so far, but they are away from the line of stability. There's no really stable targets that we can simply apply to produce them. So you need either facility like Triumph with 500 MeV proton accelerator, or you need the high flux reactors and legacy material from nuclear weapons program to produce them. So there's really create a challenge of producing them. But one thing that I really excited about different Auger emitters for targeted therapy is that you can simply produce them with small medical cyclotrons. So you can use low energy protons, and then often generated by simple PN reaction, so proton activation of the stable target, and they get produced in clinical quantity. So what really excites me as from the research point of view is making this some of these Auger emitters available for advancing these delivery systems and develop the radiopharmaceuticals for the therapy. So I think this is short answer to the last one.
That's fantastic. I think we are now officially out of time, but thank you very much for diligently answering our questions. It's been really fascinating, really good talk. So the recordings of this are going to be available on the Nuclear Masterclass website next week, and a link will also be emailed to ticket holders. And then this is the final webinar for the pre-16 masterclasses. However, for those of you on the post-16 masterclasses, next week's webinar will be finding out about the electron-ion collider on enhanced accelerator based on the Jefferson Lab in America. This is used to explore the structure of the protons, the behavior of the quarks and gluons, and how matter behaves at extreme densities. So we hope to see many of you there. As I say, thank you very much for your attendance and your attention. Thank you again for the speaker, and we'll say bye.
Thank you, everybody. Bye-bye.